Catholic University, North City Carrier, Valencia Aro Kerli. Therapeutic clearance of amyloid by antibodies to serum's amyloid P component. Definition: amyloidosis is a disease where misfolded proteins aggregate and form large deposits in tissues, leading to organ dysfunction. SPA is originally isolated as a serum-derived protein, found in all types of amyloid deposits.
Amyloidosis is the term used to describe a group of diseases in which deposits of an abnormal protein called amyloid form in tissues and organs throughout the body. Proteins are important molecules involved in almost every structure and function within our cells. They are made up of chains of smaller units called amino acids, which fold themselves into three-dimensional structures. Folding allows the protein to work properly and interact with other molecules. In amyloidosis, proteins are made in the normal way, but when they are released from the cell, they open up again. These abnormally folded proteins collect together in long chains or fibrils. The deposits they form are called amyloid. Amyloid fibrils are difficult to break down, and as they accumulate, they start to cause damage. Eventually, the build-up of amyloid fibrils stops the affected tissue from working properly. AL amyloidosis is caused by a bone marrow disorder. The bone marrow produces blood cells, including plasma cells, a type of white blood cell that forms part of the immune system. Plasma cells make antibodies to help fight infection. Each antibody is made up of 4 protein chains, 2 heavy chains and 2 light chains, which attach to each other to form the complete antibody. In AL amyloidosis, the abnormal protein that builds up and causes problems is the antibody light chain, hence the name AL amyloidosis. Instead of attaching to heavy chains, the abnormal light chains open up and bind to other abnormal light chains to form amyloid fibrils. These gradually build up over time. Amyloid light chain fibrils can occur almost anywhere in the body, but the organs most commonly affected include the kidneys, the heart, liver, spleen, nerves, and the digestive system. Treatment for AL amyloidosis involves chemotherapy, steroids, high-dose therapy, and stem cell transplant, and other drugs. Treatment is aimed at reducing the plasma cells to stop further amyloid light chains being made that would otherwise build up in tissues and organs. It also gives the body a chance to break down existing deposits naturally. However, on its own, this process can take many months or years. New treatments which break down the amyloid deposits more quickly are currently being tested in AL amyloidosis. The hope is that they can reduce symptoms and restore function quickly, and in doing so, improve quality of life for patients.
Application in nursing. Current treatment consists of support of replacement of failing organs and measures to reduce the abundance of the amyloid fibril precursor protein. A sufficient reduction of precursor supply arrests the accumulation of amyloid and can reduce morbidity and mortality.
So today we're just going to talk a little bit about amyloid. Amyloid is a very weird stuff, and a lot of things can become what we call amyloid. So over 30 different proteins now, maybe more, have been identified that can become the amorphous extracellular material which we call amyloid. Under normal conditions, proteins, as you know, assume certain folding patterns that allow them to do their job. This post-translational conformational change is intrinsic to the shape and configuration of the protein. When the protein is digested and broken down into little pieces by proteinases, those are normally recycled in the system. And those oligomers are little tiny pieces, and these oligopeptides are normally soluble and can move around and then be recycled or made into other stuff. However, in amyloid, the oligopeptides start to orient and have intrapeptide bonding that creates a sheet. Rather than assuming a alpha helical pattern, they assume a beta pleated, and in this case, anti-parallel configuration that will convert the soluble oligopeptide into an insoluble substance. And once that insoluble substance appears in the tissue, that amorphous extracellular material is what we call amyloid. So if it deposits in your cornea, you might get a cornea opacity. If it deposits in your brain, you might get a neurodegenerative disease. If it deposits in the blood vessel can become friable and bleed. And those different types of amyloid can affect us in neuro-ophthalmology. So we have cerebral amyloid, and that can deposit in your brain and cause neurodegenerative disease. We've got amyloid angiopathy, which causes the blood vessel to be friable and causes intracranial hemorrhages. And then we've got amyloid-related angiitis, amyloid beta-related angiitis, which means an inflammation, angiitis, related to an attack, an autoimmune attack on the amyloid itself. So the amyloid itself is causing the CNS angiitis. So these are the ways that it comes to us as primary CNS angiitis related to amyloid. So when we test for amyloid, we have to have special stains because it's extracellular. So the things that we are doing for extracellular amyloid testing are special stains called Congo red. And amyloid demonstrates a unique property under polarized light. It demonstrates birefringence. So we can see apple green birefringence under polarized light for amyloid. And the reason it's important to know that is because the standard stains, H&E, will not detect the amyloid unless we're actually looking for the amyloid. And so that normally means we have to have a biopsy. So the amyloid proteins that we have to worry about can arise from the light chain production, which is amyloid light chain, AL. So if you have light chain overproduction, those form the basis of the oligopeptides that become the beta-pleated insoluble sheet. You can have just the amyloid protein, AA, or you can have genetic problems in the transthyretin that can lead to predisposition and production of the protein that leads to the final common pathway, which is the production of the extracellular amorphous amyloid. These are less common. And then we have the cerebral amyloid and cerebral amyloid angiopathy. So the amyloid is kind of a final common pathway by which proteins self-aggregate into an insoluble material that deposits in tissue, whether it's your kidney, your brain, or your eye. That extracellular deposition is what causes the disruption. We need specialized stains to find it, and it can come to us in neuro-ophthalmology as deposition itself, bleeding from amyloid angiopathy, or an unusual condition called amyloid beta-related angiitis.
Pros. The effectiveness of cytotoxic chemotherapy to suppress the pathogenic clone is often limited by the function of amyloid infiltrate organs, and 20% or more of patients with amyloidosis die within 6 months after diagnosis, before the delayed benefits of chemotherapy are realized. Cons. Amyloid regression is very slow and often does not occur at all, in contrast to the usually swift clearance of other extracellular debris. And efficient tissue remodeling, there are no effective therapy for most hereditary forms of systemic of amyloidosis.
So amyloid is a sticky protein that has this tendency to clump together, and it's produced from a large precursor protein, the amyloid precursor protein. We're trying to understand how it's produced, how it then clumps together, and how those clumps of protein interact with the surface of our nerve cells and then cause the problems that we see in people who have Alzheimer's disease. If we could understand how the amyloid is produced, how it's clumping together, how it's interacting with the nerve cells, then there's the potential there to disrupt those processes as potential treatments for the disease. And so a lot of what we do is just trying to understand the basic processes that are going on in the brain and whether we can then exploit any of those as a potential therapeutic target for the future development of drugs.
Issues apply in Ecuador. Unlike 65% of cases of systemic amyloidosis are the monoclonal immunoglobulin light chain type, it is caused by B-cell decrease. A total of 16 patients, 18 to 70 years of age, of different types of biopsy prevent systemic amyloidosis were screening at Quintiles.
Today I gave an update on management of amyloidosis, what is new. In general, we have to say what is really exciting that we found that daratumumab, which is a drug that was developed for multiple myeloma and is approved for multiple myeloma, is very active in AL amyloidosis. So even as a single substance, it achieves high rate of remissions, and I presented data from Dr. Kaufman who showed that around 80% of the patients go into a deep remission who are receiving daratumumab for AL amyloidosis. Deep remission means complete remission, or VGPR, very good partial remission. What is also very exciting that this drug induces a response very fast. He showed nicely that patients who received daratumumab had a complete resolution of their abnormal free light chains within 1 to 2 weeks. So this is very important for amyloidosis, that you have a deep response and a fast response. So based on those encouraging data, Janssen started a clinical trial, a randomized phase 3 trial with around 360 patients in which CyBorD versus CyBorD plus daratumumab are compared. And if this trial shows that CyBorD plus daratumumab is superior to CyBorD alone, probably that will change our treatment approach, and patients with AL amyloidosis might be treated with CyBorD daratumumab. I also emphasize that transplant is still very important, but that despite we have very potent drug like Velcade, for instance, carfilzomib, and also daratumumab for the treatment of amyloidosis, there's still the problem of lack of organ response. So even when you achieve a complete hematologic remission, it takes around a year in median before patients show an organ response. That means before the body is able to break down amyloid in the kidneys or in the heart. And I spent, I would say, 50% of my time really in deciphering what is new in terms of anti-amyloid drugs. So basically, after the failure of NEOD-001, we have 2 drugs left. We have an anti-SAP antibody left, that's from GSK, and is currently tested in clinical trials in the UK. And we have KL101 as an antibody that targets directly amyloid, and a trial with KL101 will probably start in 2019. Both of those drugs, the SAP antibody and the KL101, showed very encouraging data as in phase 1 trials. But again, we have to show in phase 3 trials and randomized trial really whether those antibodies are able to break down amyloid. In addition, we also had a little bit in, I would say, a little bit an outbreak of TTR amyloidosis. So TTR amyloidosis is usually not treated by patients, by physicians, by hematologists. Usually TTR amyloidosis is treated by cardiologists or by neurologists. But we have two positive clinical trials. One led to the approval of parisotide. It's an antisense transthyretin drug that showed improvement of the neuropathy in patients with hereditary TTR amyloidosis and received FDA approval. The other drug is tafamidis, that is a stabilizer of TTR, and a randomized trial showed that it increases significantly overall survival in patients who are treated with tafamidis. So this is a positive encouragement that we should continue to work on the anti-amyloid antibodies despite we had the failure of NEOD-001.
Conclusion. Patients with a new diagnosis of systemic amyloidosis requires weak and safe elimination of amyloid deposits to maintain or restore vital organ function. So that's make sure to reduce production of amyloid, fibril precursor protein, and thus arrest amyloid accumulation can be effective.
Following synthesis in the endoplasmic reticulum, APP is transported to the trans-Golgi network. The newly synthesized APP protein is transported from the TGN to the plasma membrane via the endocytic pathway. APP undergoes clathrin-mediated endocytosis and is recycled back to the trans-Golgi network through the endocytic pathway. The retrograde transport of APP from the early endosome to the recycling endosome occurs through the interaction of APP with the retromer complex. Under disease conditions, APP at the plasma membrane is sequentially processed by beta and gamma secretases to generate amyloid beta fragments. This is referred to as the amyloidogenic processing of APP. Amyloid beta fragments have a propensity to aggregate and form oligomers, which eventually form large proteinaceous deposits known as amyloid plaques. APP, along with beta and gamma secretases, can be transported to late endosomes for processing. A subset of amyloid beta peptides are recycled back to the surface and released into the extracellular space. Another subset of these amyloid beta peptides is transported to the lysosomes for degradation. Amyloid beta and amyloid plaques bind to several receptors on microglia, which help clear pathogenic aggregates. Individuals with Alzheimer's disease express variants of the microglial receptor TREM2 that have reduced ability to bind to amyloid beta complexes. Amyloid beta can also drive persistent neuroinflammation by binding CD36 on microglia and rupturing lysosomes following internalization, which causes the production of inflammatory cytokines such as IL-1 beta. Amyloid beta oligomers interact with different surface receptors and can re-enter the cell via several mechanisms. Amyloid beta oligomers can mediate the formation of p75-NTR sortilin death receptors and also create pores in the plasma membrane. This results in ER stress or mitochondrial-mediated activation of caspases, which triggers the cleavage and aggregation of tau. Amyloid beta can also bind to low-density lipoprotein receptor-related protein 1, leading to endocytosis through the clathrin-dependent pathway. It can then traffic to the lysosome for degradation. Here, we reviewed how amyloid beta is generated from APP on the cell surface, and how these proteins are taken up, recycled, and/or degraded in a cell. We also covered how amyloid beta triggers caspase-mediated cell death and neuroinflammation.